Good morning to everyone and welcome to today's wonderful evening with Dr. Murli Bharadwaj. General medicine is not an ocean. It is a conquerable subject. If you focus on 118 topics, whether it is final year MBBS exam or if you are going for the NEETPG entrance, it is this 118 topics and you can revise easily around 6 topics per hour. So 120 topics, 20 hours, you become the master in general medicine. So we provide 150 pages spiral bound notes of all the content of these 118 topics. So every topic has about 50 to 60 points that you must know, must revise. Some of them are conceptual, some of them are logic based, but you need to understand, assimilate and reproduce in the tomorrow's exam. So totally 118 topics into 50 is nearly about 6,000 to 7,000 high-yield facts and concepts that you need to master from the 118 topics in general medicine. So let's continue our journey. Coarctation of aorta. So coarctation, as you know, is the narrowing of the aorta. Where does that happen? It typically happens near ductus, near the ductus. So there is ductus arteriosus, which is connecting aorta with the pulmonary artery. So after the ductus got connected, following that, there can be narrowing of the aorta, the descending aorta. So that is called post-ductal coarctation. And if it occurs before the ductus opens, that is called preductal coarctation, is what you need to remember. What is the syndrome most commonly associated with coarctation, doctor? Turner's. That's the reason any coarctation need to be evaluated for Turner's. Bicuspid aortic valve is found in 50% of cases of coarctation of aorta. And where does the narrowing typically happen? So the left subclavian will be arising near the origin of the left subclavian. Is the classic location of the coarctation, is what we have to remember. Because of this, the arm develops a hypertension and there is a decreased blood flow to the lower limb. That's the reason the leg develops hypotension, which is the combination diagnostic hallmark of the coarctation. There is a brachiofemoral delay. The blood is able to normally go into the upper limb, but there is an obstruction that is impeding the blood flow to the lower limb. That's the reason feel the brachial pulse and feel the femoral pulse. There is a delay. And because of that increased pressure proximally, there is a load on the left ventricle. Because aorta arises from left ventricle, that's the reason any obstruction will put a load on the left ventricle, leading to the left ventricular hypertrophy. Ultimately, the aorta descends down, and it is the one which gives rise to renal artery. So the moment the flow in the aorta decreases, that decrease the flow to the renal artery, and that lead to the development of renal artery secondary hypertension. Renal artery associated secondary hypertension is what you see in case of coarctation of aorta. There will be a lot of collaterals to bypass this coarctation typically, and all these collaterals typically pass with the intercostal vessels, which are passing along the lower border of the rib, that lead to erosion of the lower border of the rib. These collaterals will lead to an erosion, which is typically seen in case of coarctation of aorta. So any young hypertensive patient, upper limb will show hypertension, lower limb will show hypotension. Any young hypertensive patient with a weak femoral pulses, when you come across the combination, you will think of coarctation. Any adolescent who presents with headache, with the claudication of the leg, a little walking will lead to development of an ischemic pain. Suspect coarctation. Any neonate developing the shock after the closure of the PDA, this is a typical clinical vignette in the tomorrow's NEETPG. A neonate developing shock after PDA, it is called ductal dependent coarctation. That's how you suspect coarctation of aorta. Any upper limb hypertension with the lower limb weak pulses is the classical vignette. Any refractory hypertension in a young adult, you need to rule out the coarctation of aorta. So what are the important findings, doctor? There is a rib notching because of the enlarged intercostals. And you can see here, there is figure of 3 sign. Before the coarctation, after the coarctation, as you can see here, before the coarctation, after the coarctation, there is a dilatation. Overall, it gives a figure of 3 appearance, which is very classical. We do the transthoracic echo, which will estimate the gradient between across the coarctation, which will help you to take a decision when to do surgery. We do CT angiography, MR angiography. You can be able to know and delineate the collaterals, and it is best for anatomy. And any increase in the Doppler velocity, whenever you do, indicates a significant gradient across a narrowed aortic coarctation is what we have to remember. So they're all the investigations, doctor. So what are the complications? For a long period of time, because of the coarctation, there is a decreased perfusion to the kidneys that lead to persistent hypertension. A berry aneurysm leading to subarachnoid hemorrhage. If you operate coarctation, relieve the narrowing, once more coarctation, restenosis can very much happen. Aneurysm can form. Endocarditis risk is there in coarctation. So how do you manage coarctation? So if there is a decreased blood flow, once there is a coarctation, there is a decreased blood flow from the upper part of from the ascending aorta, the blood is passing towards the lower part of the aorta. So because the narrowing, there is a decreased blood flow. The only way the blood can enter into this descending aorta is through the patent ductus arteriosus. That's the reason when the narrowing is severe, coarctation is severe, whenever the coarctation is severe, you can give that notes to Srija. Yeah, please sit. We can put on the AC. Yeah. So how are you, doctor? Good. Today is 11th class results, sir. Ah. Achha, CBSE. Okay. So we are talking about coarctation of aorta, the topic number 5. There are totally 118 topics in general medicine which we need to master, right? So now, prostaglandin E1 keeps the ductus patent. Only if the ductus arteriosus is patent, then the blood in the pulmonary artery can flow into the aorta, and the descending aorta, which is not receiving the blood from ascending aorta because of the narrowing, will be overcome if the PDA is kept patent. So the treatment in case of a newborn with Turner syndrome who is having coarctation of aorta is giving prostaglandin even infusion is what we need to remember. Indomethacin is contraindicated because indomethacin, if you give the PDA, become closed, then the lower limbs do not get the blood supply, and that leads to the development of the shock. And any newborn baby who went into the shock with the closure of the ductus is an indication that there is an underlying coarctation which is responsible for that shock. So how do you know that there is a shock? Whenever there is any shock, there is a poor perfusion to the tissues that lead to lactic acidosis, metabolic acidosis. So any metabolic acidosis with a poor feeding neonate, you should suspect the possibility of coarctation. So how do you manage coarctation? Tomorrow, some of you will become interventional cardiothoracic surgeons, cardiologists. The moment the gradient across the coarctation is more than 20 mm, that's an indication for surgery. If there is an infant, we need to do end-to-end anastomosis by repairing the narrowing. In adults, we can use a balloon in order to dilate and place a stent is the preferred approach. And in case of infants, we don't put stent because that leads to restenosis. We need to do surgical repair. And we need to give beta blockers, ACE inhibitors to control the blood pressure. Why blood pressure happen in coarctation? Because aortic blood flow to the lower limbs is diminished. That decreases the blood flow into the renal artery. That lead to secondary hypertension due to the increased renin is what we need to remember. So there will be a lot of collaterals which will be developing into the intercostals. And often these collaterals, when they are fully developed, they will decrease the gradient, and that can underestimate the severity is what we need to remember. Right? Now, the main cause of the development of the hypertension is the diminished flow into the renal artery, leading to the activation of the renin-angiotensin system, is what we need to remember. Now, how do you know that there is a decreased perfusion to the lower limbs? We calculate ankle brachial index, which is diminished in the legs, which is a very important clue. Similarly, coarctation is responsible for a continuous murmur. On ECG, you will see a left ventricular hypertrophy. And these are the important points to remember. So what are the three important associations? Turner, bicuspid aortic valve, intracranial berry aneurysm are the three things that you need to remember. So any seizure or subarachnoid hemorrhage, you should think of berry aneurysm in a case of coarctation. Whenever there is any pregnancy with coarctation, there is a very high risk and we need to control the BP. And if you happen to put any stent in coarctation, if the patient develops fever, you should always suspect the possibility of the endarteritis is what we need to understand. So what are the important management traps to remember? Do not give NSAIDs. Any PDA closure will worsen the hypotension in coarctation. Do not rely on the gradient across the coarctation because collaterals will try to alter the gradient and difficult to depend on gradient. but still more than 20 mm gradient is an indication for surgery. Do not stent the infants. Do not ignore that even after the repair also of the coarctation, the hypertension will persist because hypertension is secondary to high renin-angiotensin is what we need to understand. So that is all the story, doctor, about the coarctation you need to know for the tomorrow's NEETPG exam. Now the topic number 6 is rheumatic heart disease. So every topic, 30 to 40 points. In them, few conceptual points. 120 topics in medicine. You are king, right? So it takes about 10 minutes per topic into 6 topics an hour. 120 topics you finish in 20 hours. Finish. Khel kadam dukan ban. Who said general medicine is very difficult? Nothing is difficult about it, right? So now, Group A streptococcus infection is the underlying cause, and there is a mimicry and cross reaction. Just like Saudi Arabia and Bahrain getting the bombs when the fight is with Iran. Autoimmune valvulitis, Ashkoff bodies are pathognomonic, and Tishkoff cells are what you typically see, which have got a caterpillar nucleus, is the typical feature in case of rheumatic heart disease. And between the sore throat and the appearance of rheumatic fever, there is a latency, is what we need to remember. Okay, so that is the story of quickly the rheumatic heart disease. Key points. Now, one of the favorite questions of the examiner is Jones criteria. Last time book this kundra unda. Okay, good. So Bachpalli Medical College. Meet Shrija. Shrija is from Gandhi. Yeah, and one of the most wonderful students from Gandhi. That's good. I'm becoming a popular teacher. So, any number of video libraries, any number of online programs, nothing can beat the pleasure of face-to-face class. I'm glad you guys have come. If you say that we will come every Sunday, we will arrange a coffee machine also, so that you will be taken care. Now, what is the Jones criteria? The most common major manifestation in the Jones is migratory polyarthritis, carditis, which is a pancarditis that lead to development of heart failure. Chorea. What is chorea? Purposeless dancing movements are called chorea. It is a delayed CNS manifestation. In fact, all other signs will vanish and only chorea will be there. That is the reason chorea is called the most specific finding in rheumatic heart disease, is what you need to remember. Erythema marginatum is a serpiginous rash. It is rare, especially Indians who are very dark in complexion, very difficult to see. Erythema marginatum. Subcutaneous nodules which are firm and painless. Remember, examiner will tease you. Painful, painless, painful, painless. What is your answer? Painless. What are the two choreas that you know? One is Sydenham chorea of the rheumatic heart disease, the other is the Huntington's chorea. And if you take the ECG, PR prolongation, PR interval prolongation. The other day I told you, what is the interval, what is isoelectric segment? Starting of the P to the, including P wave, up to the start of the QRS, up to the start of the QRS, you call it as PR interval. When you combine a wave with a segment, you get a interval, right? And only isoelectric wave is called segment. Clear? Then second important point, QT interval. What is the meaning of QT interval? The beginning of the QRS, including QRS, including ST segment, including T wave, till the end of the T wave is QT interval. Normal corrected QT interval is less than 420 milliseconds. And anything more than 600 milliseconds is considered to be prolonged QT interval. And in the ECG, you have small boxes and big boxes. Each small box is 40 milliseconds. 5 small boxes is 40 into 5, 200 milliseconds is large box. Clear? So these are funda. Okay. Now, how is the valve involvement in rheumatic heart disease? Mitral valve is most commonly affected in chronic rheumatic heart disease. So mitral stenosis, because of the fusion of the commissures, is a late sequelae. This is the commissural fusion. Fish mouth appearance is the classical feature. But in the acute phase, because of the carditis, the chamber size of the atrium will enlarge. That will make the mitral valve widen. That lead to regurgitation, only acutely. So mitral regurgitation during the acute phase is a feature which occurs because of the underlying carditis, and also that lead to volume overload. Then aortic regurgitation is once more a late sequel, and it leads to development of diastolic murmur. Yesterday we discussed mitral stenosis, aortic regurgitation. They both are diastolic murmurs. Mitral regurgitation, aortic stenosis. They both are systolic murmurs. Obviously, when the blood is pumped into the aorta and a stenotic valve is there and the ventricle is in systole, there is a systolic murmur in AS. Similarly, when there is a mitral regurgitation, when the ventricle is undergoing systole, that time regurgitation occurs. That's the reason MR murmur is systolic. Aortic stenosis murmur is, that is also systolic. Whereas MS murmur, when there is a stenotic mitral valve, then when the blood is flowing from atrium into ventricle, ventricle is undergoing diastole, you get the diastolic murmur in MS. Similarly, ventricle finished systole and it is getting filled, ventricular diastole. That time aortic blood is regurgitating. That's the reason aortic regurgitation is diastolic. Mitral stenosis is diastolic. Mitral regurgitation is systolic. Aortic stenosis is systolic. Clear? Please don't forget, doctor. So what happens in rheumatic heart disease? Because of the mitral stenosis, there is a diastolic rumble with opening snap in the apex. Remember always, mitral stenosis is a very localized murmur. Don't search across the whole blouse of the patient. Where is my murmur? Where is my murmur? Try to stand behind her like a Titanic hero. Feel the Titanic movie hero. Stand behind. Feel the apex. There you put bell of the strength, not diaphragm. Light touch. Lub dub drr, lub dub drr, lub dub drr. That is, lub is S1. Dub is S2. After that, the ventricular diastole begins. So you listen, lub, dub, drr, which is mid-diastolic rumble of mitral stenosis. Then MR murmur is holosystolic. Anywhere in the chest you can listen like a honeybee sound. Zzz, 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 is the kind of a sound of MR. It's called holosystolic. That means no S1 heard, no S2 heard. Between S1 and S2 you have systole. Between S2 and S1 you have diastole. So no S1 heard, no S2 heard. Zzz, 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 is like a honeybee sound throughout the chest. It will be radiating into the axilla, is the classical feature of MR. Then aortic regurgitation is a early diastolic murmur. We'll discuss that during AR. And a loud S1 in mitral stenosis, it's a clue when the S1 is loud in mitral stenosis. And also it indicates the valve is not calcified. It is still pliable. If the valve became calcified, no more the S1 is loud. Condition number 2, if the MS is associated with the MR also, S1 is no more loud. So S1 should be loud. If it is MS, if it is not loud, that means it is a degenerated, calcified valve, or there is an associated MR. That's what you need to basically remember. So whenever mitral stenosis is there, which chamber of the heart will have a high pressure? Left atrium. The left atrial pressure will increase. Who is opening the mouth into the left atrium? Pulmonary vein. Who is opening into the pulmonary vein? Pulmonary capillaries. Who is opening the mouth into pulmonary capillaries? Pulmonary artery. So there is a pulmonary hypertension because of the high left atrial pressure is the feature in case of mitral stenosis is what you need to basically remember. The left atrium will enlarge. So how do you identify left atrial enlargement? Left atrium, whenever it enlarges towards the right. So you have one cardiac border, and this enlarged left atrium form another border. This is called shadow within the shadow appearance, which is the hallmark of the left atrial enlargement in case of mitral stenosis. Second thing, between left atrium and right atrium, which is more posterior? Come on, left atrium and right atrium, who is more posterior? Left atrium, left ventricular posterior. Right atrium, right ventricular anterior. Immediately underneath your sternum, you have the right ventricle. And tick, 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 tick. चोली के पीछे क्या है? LA है. Right. And any LA enlargement will lead to compression of your posterior mediastinal structures, including esophagus, trachea. That's the reason you get dysphagia because of the enlargement of the left atrium into the posterior mediastinum and the compression of the esophagus is what you need to remember. So the left atrial enlargement lead to the development of atrial fibrillation. And atrial fibrillation lead to stasis, lead to thrombus, lead to embolism is a big risk. And the obstruction lead to decreased cardiac output from the left atrium into the left ventricle. The blood is unable to flow. That lead to development of exertional syncope. And all that pulmonary hypertension it caused. The left atrium, high pressures led to back pressure on pulmonary capillary and pulmonary artery, leading to pulmonary hypertension. Ultimately, will make the right ventricle to fail, because pulmonary artery arising from high pressure in the pulmonary artery will fall on right ventricle. Ultimately, right ventricle fails. Behind every successful man, who is there? A woman. Behind every successful woman, who is there? A failed, surprised man. इनको टॉप रैंक कैसे हो गया रे? मैं तो उनको पूरा इमोशनल सपोर्ट दिया, मोरल सपोर्ट दिया एग्जाम्स पास होने के लिए. Finally, when it came to entrance, she got a top rank, and this fellow is lurching. So behind every right heart failure, who is responsible? It is the left heart pathology is the most common cause, like mitral stenosis. But the failure of the right heart is a very important rule you need to remember. So what are the signs of right heart failure? Elevated JVP, pedal edema, pulsating liver, presence of ascites, bilateral pleural effusions, There are all the signs of congestion in the systemic circulation because of the right heart failure. Whereas if the left heart failure is there, what will happen? That lead to increased pressure into the pulmonary circulation, leading to pulmonary edema, is the presentation of. Give me a break. Pulmonary edema is different from pleural effusion. Okay, thank you. So now, a young patient with dyspnea with opening snap is equal to mitral stenosis, like tomorrow's exam. Any irregular pulse with mitral stenosis, diastolic murmurs, you think of atrial fibrillation. Whenever there is any hemoptysis, you need to think which valvular heart disease? Mitral stenosis, because mitral stenosis lead to a high left atrial pressure, leading to high pressure in the pulmonary capillaries, which lead to the development of the hemoptysis. And any patient with MS leading to the development of the stroke is due to cardioembolism. And any sore throat patient after a few days doing purposeless dancing movements, you will think of rheumatic fever, is what you need to remember. So we started a good drug dealer 941. Pranam Guruji. So I become a controversial medicine Baba. Good. So on the YouTube last week, lot of my students who took coaching in 2004, 2003, 20 years ago, they all appeared. The YouTube sends feed to everyone. I was so happy to see their comments, right? So we started one initiative every Sunday evening, 6 to 7 p.m. There are 2 clinical cases, 30 minutes each. All postgraduates, DNB residents, clinicians, family medicine guys, they all attend. You also attend, because ultimately you take a clinical case presentation, and how to dissect and analyze a medicine case is very important. Generally, they don't teach in medical college. So evening 6 to 7 p.m. that is online. Now, in rheumatic heart disease, AS4 titers will increase. They are a proof that there is a recent streptococcal infection. ESR and C-reactive protein will increase, but the gold standard is 2D echo. And a good number of times, the transthoracic echo from the front may not be able to detect the posterior chambers. So you need to pass endoscope. Transesophageal echo will detect any thrombus in the left atrium, is what we need to remember. And on ECG, what you find, doctor? Typically, P mitral, that is M-shaped P wave in lead 2. Why lead 2? Lead 2 you get by connecting right arm with the left leg. Our electrical activity is also passing. Our electrical activity is passing from SA node on the right side to AV node. So from the right to left, above to below. Lead 2 also is from above to below. That's the reason lead 2 perfectly represents what? Our electrical axis. Now in the left atrium, if you take, so in the left atrium, if you take right atrium, this is left atrium. Where does the electrical activity start? Atrial depolarization starts in the SA node in RA. Then it will spread to LA. So the P wave that you are seeing, which represents atrial depolarization, has 2 components. Initial component is represented by RA. Later component by LA. So together they form single P wave. But the moment left atrial enlargement is there, what will happen? The left atrial component get delayed. That's the reason the P wave become wide, and it become notched, and it looks like McDonald's M. Okay, so that is called P mitral, which is typically seen in which lead? Lead 2, where you find a widened P wave with M shape is what you need to remember. Now, if you look at the lead V1, where is the lead V1 located? On the right side. V1, V2, right side precordial, V3, V4, interventricular septum, V5, V6 are lateral and left side precordial lead. Simple. No big deal. So normally, how is the electrical activity? It is starting on the right side and leaving towards left side. That's the reason, if you look at the lead V1, you find P wave normally biphasic. Initial positive upstroke is the electrical activity generated in right atrium. Then when it is spreading towards the left side atrium, it is leaving. That's the reason in the lead V1, which is a pure right-sided lead, you find initial upstroke and downstroke. What happens in mitral stenosis with left atrial enlargement? Initial will be like that only. The later negative will become more widened. So that is the typical nature in case of lead V1. A biphasic wave where the negative limb is deeper in V1, and in the lead 2, it become M-shaped P mitral. Okay? Now, that is the story you need to remember. So how do you treat, doctor? We give penicillin, eradicate group A streptococci. Benzathine penicillin, once more, ఇందులో చాలా కథ ఉంది. Procaine penicillin, benzathine penicillin, which one is painful, painless, pharmacology. What happened to Lohita and all the gang? They said they will join maybe next week. Yeah. So if you guys are sure to come, I can plan for a longer session, 5-6 hours. 4 Sundays we can finish, 20 hours max, at most 25 hours. General medicine, khel kadam dukan band. Then surgery, gynops, that also will take 25 hours. Meeku orthopedics, pediatrics, ENT, optal. ఇవి ఒక్కొక్కటి ఒక 12 hours వేసుకోండి. 12 for the 48, అవి ఒక 50 hours. 50 hours ENT, optal, orthoped, 25 hours surgery, 25 hours medicine, 25 hours gynops. So 75 plus 50, 125 hours chalapa. If you have energy to journey with me, I'll give the notes for this 125 hours. Right? 2 students are enough. 1 student is enough for me. In the live class, no one is there boring. N number of people, let them join online, no problem. So now, to treat the arthritis, we give aspirin, steroids. What is the indication? When there is a severe carditis with heart failure, is an indication for steroid. And we give diuretics to provide the right heart failure signs. Taggichadam kosam we give diuretics. That is the story of rheumatic heart disease, clinical management. So what is the definitive intervention, doctor? You need to do percutaneous balloon mitral valvuloplasty. You'll pass a balloon, blow it, and repair the stenotic valve. Whenever there is any severe MS, but valves are still good enough, then you can do PBMV. But before you do PBMV, you need to ensure that the left atrium does not have any thrombus. That is, if there is any thrombus, contraindication for percutaneous balloon mitral valvuloplasty. Now, always there is a sandigdham, enigma, ambiguity between whether to repair or replace, whether to always in life, that is the common confusion, no? Whether to replace a boyfriend or repair the boyfriend. Which is cheaper? Replace is cheaper. Correct. So, in case of mitral valve also, in mitral stenosis, we try to repair percutaneously, making the boyfriend to listen. But repair is generally preferred if the LV function is not yet affected. And replacement is required if there is any severe calcification or MS में MR भी शुरू हो गया तो, then you will do replacement. And if the MS has an AF, don't do PBMV, but you try to give warfarin is considered to be the management. Now, common question asked in the exam. MS with AF is because of dilated left atrium, because the high left atrial pressures for a long period of time. Then pulmonary hypertension is because of the high LA pressure over a period of time will cause a back pressure on the pulmonary capillaries leading to pulmonary hypertension. Then how do you know how severe is mitral stenosis? So whenever there is any mitral stenosis, a stenotic valve will make a sound called opening snap when it is opening. Just like champagne cork. The moment you open the champagne cork, it will pop out because of the underlying pressure, the pressure of the gas underlying the cork. So, now, when will the mitral valve will open? After the closure of aortic valve. Closure of the aortic valve lead to second heart sound. So the distance between opening snap and S2, the moment S2 close, immediately if the OS happened, that's called S2 OS gap or interval, is narrow. What does it mean? In a S2 bandagangane, it open and quick ga. That means the pressure in the left atrium is waiting. As bandagangane, it open. But if at all the mitral stenosis is not severe, then the S2 OS gap will be more. Could you get me? See, S2 indicate what? Closure of aortic valve. After that, the mitral valve will open with a OS. If the left atrial pressure is very high, the minute S2 happen, immediately without waiting 1 second also OS happen. So S2 OS gap is narrow means mitral stenosis is severe and LA is very high. So the best indicator of the severity of the MS is S2 OS interval. Shorter the interval, more severe is what we need to remember. Clear, doctor? Now, what is the cause of the hemoptysis in rheumatic heart disease? Favorite Viva was question. Because the pulmonary hypertension, the bronchial veins will have high pressure and they rupture and leading to the development of hemoptysis. It is a bronchial vein rupture because the high pressure in the pulmonary vein is responsible for hemoptysis in rheumatic heart disease. Now, doctor, always cardiology is very interesting because If at all there is any logic in the entire medicine, cardiology, right? So yesterday there are 100 PYQs in the chapter rotatory motion in physics. I was solving with my younger boy Abhinav and his classmates. So we kept alarm. Per hour, how many questions we solve? The kids are too sharp. Top. They don't need a pen also. They're directly telling cos theta of what, sin theta of what, and how the answer is. Not like it felt, wow. I got the same kick of 30 years ago. So there used to be 5 of my friends. They were preparing for IIT joint entrance. I was the only biology guy in that. But I used to outpace them. All the 5 joined IIT. One is now the academic dean in BITS Pilani. So, Spardhaya Vardhate Vidya. Always we need to, there is something called cohort effect. What is the meaning of cohort effect? Some will be good in logic. Some will be good in memory of the facts. The one good in logic need not be good in memory of facts. He may forget what is the diameter of mitral valve. But he can understand why the opening snap occur and what is the relation between S2OS. The logic he will understand. But when you are a cohort, right? When you are all competing together, automatically this fellow's memory will improve. This fellow's logic will improve. Ultimately, they achieve an uniformity. That's the reason always we should be surrounded by Gandhians. Lohita and everybody, very sharp. Right? So, they all attended pathology and microbiology, pharmacology. Achu Gudinet ave question vachni. Mano edaithe booklet ichinamu. I'll also give you a KNR UHS last 10 years papers analysis. Aim question look, batti gottale last moment ki. Ive untai. Kabatti 120 topics are also too much. 118 topics are too much, and the gyan on each topic we are studying is too deep. For passing MBBS exam, you require hardly 1/10 of this. But you have time, you can scale up. So now, doctor, mitral stenosis, what will that lead to? Narrowed mitral valve. That lead to increased left atrial pressure. And that LA pressure will exceed. Now we are talking about what? Why A2OS gap is a, S2OS gap is a indicator of severity. So when will the mitral valve open? When the pressure in the LA is higher than the pressure in the left ventricle, that will make it to open. So when the left ventricle finishes its systole, it is emptied and S2 closed, aortic valve closed, and the pressure in that is low, and the pressure in the LA is already high because of a stenotic valve, and that will make the valve open. So the opening snap occurs immediately after the A2 if the pressure in the left atrium is high. And that's the reason A2OS interval will shorten, and indicator of the severity of the aortic stenosis is what we need to remember. Now the next question. Why there is a loud first heart sound in case of mitral stenosis? What is the logic? Bhaiya, S1 kaiku hoga, closure of mitral valve will lead to first heart sound. Now let's look what happens in mitral stenosis. In the mitral stenosis, when the valve is still mobile, there is an increased left atrial pressure. Why left atrial pressure? Because this is a stenotic valve and the atrium is trying to push the blood into the ventricle. All the blood will not fill in the atria will not go into ventricle. So some will be left. The regular venous return once more brings the full blood plus previous homework left over. Together will cause a high left atrial pressure. And that high left atrial pressure, right? The high left atrial pressure will keep the mitral valve open for a longer period of time when the ventricle is filling, right? And when will mitral valve will close? After the ventricular filling is over, mitral valve will close. But because of this high pressure, the two valves are kept wide open throughout the diastole. So at the time of closure, they are wide open. That makes a loud S. That's the underlying philosophy. High LAP, keeping the valves wide open, will make the valves to shut down, and at the end of the diastole with a bigger sound, which is loud S1, is what we need to remember. Clear, doctor? Now, what are the complications of rheumatic heart disease? Atrial fibrillation is the most common arrhythmia. It can lead to thromboembolism, pulmonary edema, right heart failure, infective endocarditis. 5 tuckman guruthirale. Now, always remember, whether it is MS, AS, AR or anything, they're all the sequelae of a chronic rheumatic heart disease. So, acute rheumatic fever may. There is acute rheumatic fever, chronic rheumatic heart disease. These two are different. In acute rheumatic fever, if at all you listen a murmur, it is because of what? Carditis leading to the widening of the chamber, leading to the regurgitation. Acute MR is the only thing in ARF, acute rheumatic fever. But chronic rheumatic heart disease will lead to MS, MR, AS, AR. Now, whenever there is left atrial enlargement and there is a clot, you need to anticoagulate. For anticoagulation, you have two choices. You can use nicumarolone, warfarin, all this. Acetrom is a common brand, 2 milligram, 3 milligram. That is nicumarolone, which is the warfarin congener. You have modern direct oral anticoagulants, which are available. The rule is to anticoagulate in MS, only warfarin and direct oral anticoagulants are not useful, is a very important point you need to remember. Then second important point, don't forget. All the stenotic lesions worsen in pregnancy. Why? Pregnancy is a state of increase in plasma volume by a significant amount. So if the regular heart receives 5 liters, you receive 8 liters. So if the lesion is stenotic, what will happen? 5 push cheyaleka chachipothundi. Old question papers to study and pass exam only is difficult. On the top, you are giving it Harrison's internal medicine and big plan A, plan B notes, 6,000 pages to read. Where will it? No, it won crash course. So pregnancy is Harrison for a stenotic valve. All stenotic lesions worsen with pregnancy. Then what happens to regurgitant lesions? Regurgitant lesions. In pregnancy, there is a high progesterone. Progesterone leads to smooth muscle relaxation. So the vascular smooth muscle is relaxed. And the relaxation of the vascular smooth muscle will lead to total peripheral resistance to fall down. If the total peripheral resistance falls down, the heart pumping forward will improve and regurgitation will decrease. Once more, high progesterone in pregnancy leading to smooth muscle relaxation of the blood vessels. leading to fall in the TPR, leading to decreased afterload, leading to improved forward flow, leading to decreased backward flow. That's the logic. So what will you remember throughout life? All regurgitant lesions improve with pregnancy. All stenotic lesions will worsen with pregnancy is what you need to remember. So that is the story, doctor. Now, important management traps. Don't do percutaneous balloon mitral valvuloplasty if thrombus is there, because it can lead to embolism. You're trying to pass a guide wire and try to thrombus, embolism. So do not use direct oral anticoagulants if there is any, in case of rheumatic MS, as anticoagulant. Don't ignore AF. If AF develops irregular pulses, they immediately anticoagulate. Don't delay the surgery, because if the MS will go into MR and AR, it is beyond the point of repair. If a patient of rheumatic fever came to rheumatic heart disease, come to you, still MS is only there, MR and AR has not yet developed. Push them for an open heart surgery. Right? That's very important. They'll say, Dr. Garu, little MS only, no. I have one senior obstetrician. When will you suspect rheumatic heart disease? When multiple valvular lesions are there in a person, suspect rheumatic heart disease. So with multiple valvular lesions, I asked many times, did you have any time rheumatic fever? No, I'm all right, everything. She's a gold medalist from Andhra Medical College. Then her friend, who is a pediatrics professor, she told, hey, don't you remember in second year MBBS, I only used to give you the Penidure injection. Ah, right. So who forgot? Patient forgot, but her friend who gave remembered. Closest friend. So she had rheumatic heart disease. But only MS was there. So our argument is only MS, no. Please, I don't want a open heart surgery. Really also they take out the heart and repair and then push the heart back. Who want it? So in all those scenarios, you will do a cardiac catheterization. Look, how is the pulmonary capillary pressure, wedge pressure, which is an indicator of pressure in the left atrium. And you will calculate how is the pulmonary hypertension. If the pulmonary hypertension developed, if the pulmonary capillary wedge pressure is high, the high pressure in the LA within no period of time lead to LA enlargement, AF, regurgitation. That time you can't repair also. So with a lot of persuasion, she ultimately agreed and undergone a surgery, and now she's absolutely all right. So that's the story of valvular heart disease and rheumatic heart disease. What I'm telling you is, if you read Davidson, you don't get stories. But the purpose of a teacher is basically to tell you the real clinical story, so that you won't forget the subject. So, doctor, opening snap plus diastolic murmur, MS. AF plus MS, anticoagulate. If the AS4 titers are high, plus arthritis, you think of rheumatic fever. Severe MS, percutaneous balloon mitral valvuloplasty, we will try the best. Penicillin prophylaxis is lifelong. Penicillin is available simple way. Suppose if the rheumatic fever happened in the childhood, then the rule is, there are different rules. We'll take up the prophylaxis protocol. Now, That is all the story, doctor, of rheumatic fever. Now comes topic 7. Good. Any PDF of all this? Yes, yes. We have 150 pages PDF available. 150 pages PDF. Please, of 118 topics. Please WhatsApp our helpline. They provide you. Yeah. So, doctor, cardiac tamponade. Let's talk about this. We finished 1 hour. We'll 5-minute voice break. Yeah. Manu, just post. So it's a happy moment. My younger boy, all 60 out of 60. Biology, physics, chemistry, and so IP exam is a cheap chitka exam. Huh? He wanted to be a movie director. He is against going to medical school. Out of courtesy on me, he said, "Okay, I'll get top rank, but I won't join medicine. I'll go to Hollywood to become a director." Actually, they become more successful. मेडिसिन में क्या है? ओ एमडी होने के बाद 1 लाख तनख्वाह मिलने के लिए मेहनत करना पड़ता. There are millions of thousands of MDs. What's the big deal? Only if you are professional, you know how to acquire patients, how to tell Maya Matalu, then that is a different story. How well you can be able to sell yourself. That's an unfortunate thing. They don't teach in med school. So, but above all, if you have an empathy, love, kindness, connectivity with the patient, automatically you'll become successful. That is the rule of the game. So let's continue our journey, doctor. Yes. We'll persist some more 5 to 6 more topics before we call it a day. So cardiac tamponade, what does it mean? There's a lot of fluid around the heart, inside the pericardium, that will cause the compression of the chambers of the heart, which is called the cardiac tamponade. Because there is a pressure outside and compressing the chambers of the heart will not be able to get filled with the blood. So, impaired diastolic filling is the hallmark of cardiac tamponade. When do you call cardiac tamponade? Just the mere presence of the fluid around the heart is not enough to be called, for you to call cardiac tamponade. It is only effusion. The moment the fluid is significantly causing a compression and impairing the diastolic filling, and the time of the diastole, it is supposed to get filled chambers. But if they collapse during diastole, diastolic collapse of the ventricles demonstrated on the 2D echo is the hallmark to call that as cardiac tamponade. Very important. Then tamponade depends. It's an emergency. Absolutely. You have to put a pigtail catheter and drain the fluid out. Right. So while doing that procedure in a HIV positive patient, I got stuck with the HIV needle. It was an emergency. It's dyspneic. So I was in second year MD. Tuck pigtail catheter and then push. Fluid was draining. Patient is getting relief. That time the needle stuck. I took 1 month of antiretroviral. So what I'm trying to tell you is tamponade is equivalent and proven by diastolic collapse of the ventricle is the hallmark of the tamponade is what you need to remember. Then another important thing. If you take the RA pressure, RV pressure, LV pressure, all of them equalize. That happens when there is a lot of pressure from outside. Normally RA, RV, LV pressure, all of them are not equal. Equalization of the pressure in all the 4 chambers is another hallmark to define the cardiac tamponade. Then you get pulsus paradoxus. What is the meaning of pulsus paradoxus? Whenever you take inspiration, there is a negative intrathoracic pressure which sucks the blood into the right side of the heart. And that increased blood in the right side of the heart normally will cause the push of the interventricular septum and make the left ventricle size to become smaller. That will decrease the cardiac output. That will decrease the pulse, that will make the pulse to become weak. Right? This is a normal finding. If you look at your pulse also, every time you are inspiring breathe, your pulse become weaker. But if there is any tamponade, this phenomenon become exaggerated. It is exaggerated so much that the decrease is so high that the cardiac output almost goes to nil and the pulse is impalpable. Normally pulse become weak, but with cardiac tamponade it become exaggerated and pulse become impalpable. Then why you call paradoxus? It is called paradox because if you put the stent on the heart, heart is beating, but pulse is not there. That is the paradox. Subtle shift during inspiration leading to the decrease in the size of the LV, leading to decreased cardiac output, leading to the loss of the pulse while still the heart is beating is the paradox, which is the hallmark of cardiac tamponade. So what is the Beck's triad in cardiac tamponade? Because of the pericardial tamponading effect, the ventricles got collapsed, that decreased the cardiac output, leading to the hypotension. And because the filling is not happening, all the blood coming from the jugular vein could not enter into the right atrium, the jugular venous pressure is elevated. And when you are trying to auscultate, because of this fluid, there is a muffling of the sounds. So hypotension plus elevated JVP with the muffled sounds is equivalent to the Beck's triad, is what you need to remember. So there is a low BP with a high JVP is the classical feature, right? Where low BP with high JVP, the moment there is any shock. Muffled heart sounds, classical feature. Then when do you call pulsus paradoxus? How much decrease in the pulse pressure at the time of inspiration? More than 10 millimeters mercury decrease in the systolic BP during inspiration defines the pulsus paradoxus. Examiner's favorite question. How many millimeters of mercury or pressure? Whenever you do inspiration, there is an increased filling of the RV, which will decrease the LV volume due to the interventricular septal shift, leading to the development of decreased stroke volume output and cardiac output. That decreases the pulse, is what you need to remember. There is also an elevated, there is also COPD and tamponade. What is the differentiator? JVP is elevated, means it favors tamponade. All right. So let us quickly look at the pathophysiology, doctor. Inspiration decreases intrathoracic pressure, increase the venous return, RV will expand, and that lead to, because of the fixed space to the tamponade, interventricular septum shifts to left and decrease the left ventricular filling, decreases the LV stroke volume, decreases the systolic BP during inspiration, which will drop more than 10 millimeters of mercury. That defines the pulsus paradoxus. You have to tell in the tomorrow's exam, right? Next, because of the pericardial effusion, why JVP increases? There's an increase in intrapericardial pressure, external compression, impaired diastolic filling. The blood will go back into the systemic veins, and there is a rise of the jugular venous pressure, is what we need to remember. Why COPD is a differential diagnosis to tamponade? Both will lead to pulsus paradoxus. but pulsus paradoxus without JVP is COPD, with the JVP is tamponade. Adi. That is what you have to remember in the exam. Now, when the heart is oscillating in the fluid around it, if you do the ECG, one wave small, one wave taller. That's called electrical alternance. You see, this small wave, small, large, small, large, small, large, small, large. This is called electrical alternance, is what you need to remember. Please review a video which is still there on the YouTube. 55 ECGs for NEETPG exam. It is about 1 hour session. Take opportunity. Yeah. Now, అవును మీరు పట్టుకొస్తున్నారు మీ దోస్తుల్ని ఎవరిని పట్టుకురాలి? You will be permitted only with other friends of you next class. So, low voltage ECG. But మీరు ముగ్గురు సరిపోతారు నాకు. 10 hours పుట్టమని క్లాస్ తీసుకోమని చెప్పగలుగుతాను. ముగ్గురుంటే చాలు. But still bring a little bit of awareness among your friends. Then the heart will be big in diameter. That's called water bottle heart. Whenever there's a large effusion is what you need to remember. So you can see how the heart looks like. The cardiothoracic diameter will increase enormously. It's called the water bottle heart in case of cardiac tamponade. And you can see the overall waves will be of a low voltage and they will be oscillating in their voltage, which is called electrical alternance. Then what is most important, you can see here, when you do 2D echo, you are able to see always 2D echo is different than regular diagram. In the regular diagram of our biology teacher, what is the diagram? Atria above and ventricles below. But in case of 2D echo 4-chamber view, these are ventricles above and atria below. Right? So, what happens here? There is a diastolic collapse, which is the hallmark on 2D echo in a 4-chamber view, which you need to demonstrate. So, RV diastolic collapse, most specific cardiac tamponading find. And very early, systole only right atrium will collapse. RA systolic collapse is early tamponade. RV diastolic collapse is specific tamponade sign. And if you look at the mitral inflow, respiratory variation, if it is more than 25%, that means there is an impairment of the filling of the atria, right? Impairment of filling of the atria in case of cardiac tamponade. More than 25% variation in the filling of the mitral valve with respiration, inspiration, expiration is another 2D echo finding. And all that blood which is not able to fill will get stagnated into SVC, IVC. So IVC become plethoric, which is indicative of high RA pressure because of the tamponading effect on the surrounding fluid, is another important echo hallmark. 4 echo findings: RA diastolic collapse, RA systolic collapse, respiratory variation more than 25% on the mitral inflow variation, and IVC plethora. Are the hallmark is what you need to remember. Then, if you look at the JVP, there is a blunted Y descent. Mala idoka story unnadi. Jugular venous pulse. Anyway, I'll discuss that as a separate topic, but still quickly. What is Y descent? Descent is decrease in pressure. It is the decrease in the pressure in jugular vein, which is the decrease in the pressure in atrium. When will atrial pressure will decrease? When all the blood in the atrium runs into ventricle. So the moment the AV valve opens and the blood in the atrium moves into the ventricle quickly, the pressure in the atrium will fall down, and that lead to a sudden descent, which is called Y descent. So what happens in case of cardiac tamponade? The filling of the ventricle is not happening during diastole. So it is not, and it is collapsed. That means the atria is unable to empty into ventricle. That's the reason the pressure in the atrium will not diminish. That's the reason the Y descent will become blunted, which is a mark of an impaired ventricular filling, which is seen in the case of the cardiac tamponade, is what you need to remember. Now, few important clinical vignettes in the NEETPG and USMLE exam you have to be sure about. After MI, whenever there is any sudden shock, what is the possibility? MI has caused the weakening and necrosis of the free wall that undergo rupture, leading to the tamponade. Blood in the heart chamber moved into pericardium. That lead to sudden shock. Think of tamponade. Any cancer patient with dyspnea, there are metastases that happened into the pericardium, leading to rapid collection of the fluid, especially lymphomas, will lead to malignant effusion into the pericardium, leading to the development of the tamponade. Any trauma patient develops hypotension with an increased JVP, the steering hit the sternum caused rupture of the pericardium, leading to the pericardial tamponade. Any dialysis patient presenting with effusion, think of uremia leading to pericarditis, leading to pericardial effusion. Any patient on anticoagulant can develop the hemopericardium and can go into the pericardial tamponade, and shock is what you need to basically remember. Of all, what is the most common cause? It is a trauma. Subacute, most common cause, malignancy. Chronic effusion, uremia. Post-MI can lead to tamponade. Sometimes when you are passing a central venous catheter, the catheter tip can cause the injury to the pericardium, and you are still trying to negotiate. First year DM cardiology. That can lead to catheter-induced pericardial effusion. Pacemaker, when you are trying to place, you deeply made an entry and ruptured the pericardium. You made pericardial effusion get created. How do you manage? Pericardiocentesis is emergency management where you pass at 30 degrees in subxiphoid area, directed towards the mid-clavicle, is the typical direction where you are aiming the apex of the heart. And we give IV fluids because the whole problem is filling of the right heart. So if you happen to give IV fluids, you will increase the preload. That will make the filling happen. It's not fluid restriction, it is giving IV fluids is the treatment. Then echo-guided drainage, 2D echo lagake. So they are the part. Now what are the important tips? Do not delay the drainage in a hypotensive patient. You have to put emergency pictate. Do not give diuretics that will decrease the preload and worsen the diastolic filling. Always rule, right heart खराब हो गया तो fluid देना, left heart खराब हो गया तो diuretic देना. If you do the reverse of that, no, hey Ram, patient will say and die. Right? You are Nadhuram Godse. So then, a lot of times that happens. Patient comes with decay. He has got shortness of breath. Treatment of decay is to give fluid. Lagao, normal saline. Similarly, a patient who has got a pulmonary edema comes, he also presents with SOB. If you don't put stethoscope, then you will hear crepitations of pulmonary edema. There you have to give diuretic. In decay patient, he is dehydrated and the lungs are clean. Don't give diuretic, give fluids. So if you miss that stethoscope to check the auscultate, and sometimes there can be a combination. A pulmonary edema patient with decay, their glucometer will help you. Huh? So, next, tamponade, absent by descent. But constrictive pericarditis, there's another entity called constrictive pericarditis. Where do you get this? हम इस देश के वासी हैं जिस देश में टीबी बहती है. Because of the TB, the pericardium become fibrous, constricted, and it will impair the cardiac filling. That is constrictive pericarditis. There also JVP is elevated. Right. How do you differentiate? Here there is a prominent Y descent, whereas in tamponade, there is absent Y descent. Now the question comes. Why the Y descent is prominent in case of constrictive pericarditis? What's happening in constrictive pericarditis? So let us look into the pathophysiology coolly. There are two kinds of students, doctor. Batti marne ka aadat ho gaya to it is worse than marijuana. You have to constantly question why, where, when, right, and how. If you forget your WWWH, you sold your soul to Satan. Remember that in life. For anything in life. Why should I marry? Why should I break up? Why should I remarry? Why should I romance? Everything is why, when, where, and how. Right? So a rigid, non-compliant pericardium is there. Right? Around the heart. It will limit the expansion of the cardiac chamber. Now, at the start of the diastole, when the ventricle is getting filled from atria, the AV valves open. And the atrial blood, atrial chamber is surrounded by a stiff, non-compliant pericardium. What will that do? It is already because of filling from the great veins, pressure in the atrium is high. On the top of it, bahar se, it is squeezing. The moment AV valve open, what will it do? It will rapidly fill unrestricted into the ventricle, and there is a sudden fall in the RA pressure that leads to a prominent Y descent. And after that, what will happen? The ventricle, when it is getting filled, is expanding, and that time the stiff pericardium around it will say, no, sorry, that atrium pushed blood, but you can't fill beyond this point. And it will abruptly stop the filling. Then what will happen? The fall in the pressure in the atrium will not further fall. It will once more rise and plateau. So, dip and plateau, otherwise called square root sign in the atrial pressure, it will tell. At the time of the early diastolic filling of the ventricle, it will fall because the stiff pericardium around the atrium is squeezing and pushing the blood. But when the ventricle is filling, the surrounding stiff pericardium will prevent it to get filled anymore. Then the pressure once more in the atrium will rise back and plateau. Square root sign, dip and the plateau, prominent tech, Y descent. These are all the features of constrictive pericarditis is what you need to remember. Doctor. Now, so constrictive pericarditis is having a prominent Y descent. Cardiac tamponade has an absent or blunted Y descent. Is the story. If you know, doctor, you are on par with me. Okay? You go and ask your interns, hey, why there is a square root sign and plateau deep? They might have never heard also. MD general medicine first year resident ko pucho. How many will tell with clarity? Right? So what is the purpose of coming here every Sunday? To get equipped with enough ammunition to go and attack them. I'm preparing Lebanese, Iranian soldiers to fight against the postgraduates who are the Donald Trumps. Right? Maza aata when you trick them. Right? Today, after ChatGPT came, all these flowcharts I prepared from ChatGPT only. I told her, I'm a dumb teacher. How can I explain to the dumbest student in the class about why the dip and the plateau occur? Can you give me simple steps to understand? Huh? So you too can ask, it will give you the notes. Right? So, Kusumal sign is the hallmark of constrictive pericarditis. What is Kusuma? Let's talk about Kusumal sign. Normally, when you are inspiring, there is a negative intrathoracic pressure, which will suck the blood in the great veins into the right side of the heart and make the great veins to empty and collapse. But whenever there is any constrictive pericarditis, the atrial pressure, because the surrounding tight pericardium already is high. So during inspiration, when you are trying to push more blood, what will atrium will say? Already nindina. చుట్టూతో ఇదొకటి గట్టిగా అతుక్కున్నాను పిసుకుతున్నది. మళ్ళీ దాని మీదకెళ్ళి నువ్వు ఇన్స్పిరేషను నేను ఎక్కువ బ్లడ్ తెచ్చినా తీసుకోవాలంటే తీసుకున్నాపో అన్నట్టు. సో ఆల్రెడీ ద టైట్ పెరికార్డియం ఈజ్ స్క్వీజింగ్ ఇట్. It is already pregnant with blood. On the top of it, inspiration is trying to push more blood. It won't accept. And the jugular vein, which is supposed to collapse during inspiration because of increased filling, doesn't collapse and it remains prominent. So, absence of the inspiratory collapse of the jugular vein, because right atrium no more is accepting the applications into residency matching program, because it is being constricted by the surrounding stiff pericardium, is called the Kusumal sign, which is the hallmark of the constrictive pericarditis, is what you need to basically remember. Now, it is only seen in constrictive pericarditis, but not in tamponade. Why? Let's talk. Once more, I asked ChatGPT, I'm a dumb teacher with the dumbest student. D2D. I'm in D2D business. Dumb teacher to dumb student, like B2C. So cardiac tamponade, pericardial fluid is there, intrapericardial pressure is high, heart chambers are compressed, there is a diastolic collapse of RA-RB, diastolic filling is impaired at all times. Now inspiration occurs, right? Decrease intrathoracic pressure, increase venous return. But heart cannot expand because of the external compression, and there's a limited transmission of the venous return to there is uh, uh, see, difference between constrictive pericarditis and pericardial effusion is pericardial tamponade is like this. In case of the constrictive pericarditis, it is not naturally collapse. It will get filled. Only not additionally filled during inspiration. Ikkada, whether it is inspiration or expiration, it is not ready to get filled at all. So that is the reason in the case of the tamponade, you don't see anything like JVP does not rise, what you call as, at the time of inspiration only, JVP remains prominent kind of a Kusumal sign is unlikely when there is a tamponade. Because in tamponade, whether inspiration or expiration, it is not ready to fill. Whereas in the case of the constrictive pericarditis, during diastole, some filling is there. Only further increased filling is not there during inspiration. So, Kusumal sign, which is inspiration causing the collapse of the jugular vein, which is absent, is the special feature of constrictive pericarditis, but not tamponade. That's the point you need to appreciate. Okay, tamponade is a fixed external compression, no extravenous accommodation, no inspiratory JVP rise, is what you need to remember. Right? Now, quickly, what are all the difference between cardiac tamponade and constrictive pericarditis? Harshad is asking, sir, should we make notes of this class? No. Nowadays with ChatGPT, where is the notes? I am already giving you from ChatGPT only. So I'll give you a printed notes, Dr. Harshad. Please do call 9000-868-356 to get printed notes, printed 150-page notes. Right. Now, tamponade versus constrictive pericarditis. First, where is the pathology in tamponade? There is a fluid around the heart and it is under pressure. Here, there is a thick, rigid pericardium. Tamponade is acute. This is chronic. Constrictive pericarditis. TB is responsible. JVP is elevated in both, but more so in tamponade. Y descent is absent in tamponade, but prominent in pericarditis, constrictive pericarditis. Kusumal sign is absent in tamponade, but inspiratory prominence of the JVP, a feature of constrictive pericarditis. Pulsus paradoxus is a feature of tamponade, but not constrictive pericarditis. Heart sounds are muffled in tamponade, but here, every time the heart is getting filled with blood during diastole, it will hit the thick pericardium, tuck, that's called pericardial knock, which will be heard, right, during diastole. Then the BP is low, Beck's triad, in cardiac tamponade, but usually normal in constrictive pericarditis. So, filling pattern is always restricted in cardiac tamponade. That's the reason the Y descent is absent. But here, early rapid filling followed by the rise and plateau, which is called the square root sign, is the hallmark of constrictive pericarditis. Clear? You'll remember that, right? So, in cardiac tamponade, systole begins Tricuspid valve pulled downward. Now why? Now next important thing is X descent. How it is, right? Y descent is over. X descent, how it is in JVP, let us talk. First you need to know what is X descent. Why does it happen? Descent and decrease in pressure. So there is a decrease in pressure in the atrium 2 times. One time during the ventricular diastole, suddenly when the blood empties into from atrium into ventricle, that time there is a fall, descent. That is called Y descent. Then where do you get X descent? Unlike Y descent, which is a diastolic event, X descent is a systolic event. When the ventricle is undergoing systolic, when daddy went to office, what will mummy do? She'll stretch her legs, open up a nice TV serial, and have a little Bournvita or coffee, Horlicks, whatever. If it is England, it is little scotch. But in India, so atrium is relaxing when the ventricle is undergoing systole, right? And that lead to a fall of the pressure in the atrium, which is responsible for X descent. There is one more reason. When the ventricle is undergoing systole, it will pull down the tricuspid AV valve. That will increase the size of the chamber. That also will decrease the right atrial pressure. So systole begins, tricuspid valve is pulled downwards and RA pressure will fall, and that lead to X descent. Right? So in case of cardiac tamponade, this tricuspid valve getting pulled down during the systole will be very prominent. And that's the reason the X descent is very prominent. Okay? Just check the Sapna is calling. Sapna is calling, just check. Okay? So X descent is preserved and prominent, Y descent is absent, that is cardiac tamponade. Now coming to constrictive pericarditis. Why X descent occur? Atrium relaxation, tricuspid downward movement, RA pressure falls, and this will be happening more prominently in constrictive pericarditis. That also will make a prominent X descent. So both in tamponade constrictive pericarditis, X descent is prominent, but Y descent is absent in tamponade. But Y descent is prominent with a square root sign in finish. That is all the story you need to know, doctor. Right? ఇవన్నీ ఏంటంటే డాక్టర్ ఫిజిక్స్ PYQs in NEET laga రివైజ్ చేయాలి. You have to keep talking about this in the wards, in the rounds, in the patients, with the patient, in the library. Then you will remember the logic. Okay? Then you should quiz. Hey, if there is any, what is the contraindication for percutaneous balloon mitral valvuloplasty in MS bolo? And presence of thrombus, and all answer. Hey, you need to anticoagulate. Do you give DOACs or warfarin? Whom will you ask this question? To the friends who don't know what are DOACs. What is meant by direct oral anticoagulant? What is meant by indirect anticoagulation? Adantha pharmacology story unnadi. Yeah. So cardiac tamponade. Whenever there is any aortic dissection, it can lead to tamponade. Right? Why aortic dissection lead to tamponade? Ascending aorta arises from the left ventricle. So if there is an aortic dissection, there is a blood seeping through the wall of the aorta, which will seep into the pericardium. That lead to tamponade. But there, putting pigtail catheter and draining is not the purpose. Then if you try to drain, what will happen? The blood in the aortic valve will pass through the pericardium through your drain outlet. You are creating a blood transfusion line. You can put to the next patient who has anemia. Right? So there it is the surgery. Any malignant pericardial effusion, it will be recurrent. So you need to do pericardiectomy. Then TB effusion, how will you identify? You need to do ADA levels, which are increased, and you need to treat by anti-TB therapy, not just the effusion repair. Dialysis is the treatment if the effusion is due to uremia, is what you need to remember. So, doctor, these are some of the important things about the topic called tamponade. Huh? So, very good. ఉన్నదా పెట్రోల్ ఉందంటే ఇంకొక 4-5 టాపిక్ లేపేద్దాం పక్క ఎనర్జీ నో ఎనర్జీ 5-minute break. Okay, after 5-minute break, let us rejoin. So, welcome back to the session. Cardiology, valvular heart diseases is all about ASAR, MR, S1, S2, S3, S4, systolic and diastolic murmurs. So, there are some topics in the middle we'll take next. Topic 21, you jump to. Now, doctor. In aortic regurgitation, what is the hallmark of aortic regurgitation? A early diastolic decrescendo murmur heard along the lower sternal border is the hallmark. Okay? So, could you be able to relate why it is a diastolic murmur? Obviously, the blood in the ventricle is emptied into the aorta systole. End of the systole, aortic valve closed, mitral valve opened. Blood is moving from left atrium into left ventricle. That is the time where the blood which is being pushed into the aorta started to make a comeback. That's the reason regurgitation, AR, is a diastolic event. The murmur is also diastolic, right? And it is a decrescendo. That means it is decreasing in intensity. That means the regurgitation initially is exuberant, slowly it diminishes. That's the reason it's a decrescendo murmur. And where is it heard? Lower sternal, left sternal border. So normally, what is the pulmonic area? Second left intercostal space is called pulmonic area. Even though pulmonary artery arises from right ventricle, the blood will move towards from the right towards the left. So left second intercostal space is pulmonic valve. Right second intercostal space is aortic valve. So you expect aortic regurgitation murmur somewhere in the right side, but that is not so. The regurgitant jet from the regurgitant jet is moving back into left ventricle. So left parasternal fourth intercostal space is called here neo-aortic area. Once more, summary. Left second intercostal space is pulmonic area, right second intercostal space is aortic area, but fourth left parasternal border is neo-aortic area, into which the regurgitant jet is happening, is what you need to remember. Agreed? Then it is diastolic. Lub, dub. How will be heard? Lub, dub. Like a post-coital sound. Right? Lub, dub. Right? So, you need to ask the patient to lean forward. Ask him to hold the breath. Then you need to listen. Why? Because the respiratory sounds have the same frequency as the, which is the diastolic murmur of aortic regurgitation. So, lub, dub is the typical early diastolic murmur of aortic regurgitation, which is typically heard in the left sternal border in the fourth intercostal space on the left, which is neo-aortic area, with the patient sitting and leaning forward and holding his breath will make you to listen. Then, will you listen with diaphragm or bell? If it is mitral stenosis, lub, dub, has a high amplitude, low frequency. Whereas here, lub, dub is having a low amplitude, high frequency. So you need to use the diaphragm. You need to press the diaphragm so hard that the shape of L, Littman, should imprint on the chest. Always diaphragm, use pressure. Bell, light touch. Remember. High amplitude, low frequency sounds, bell. Low amplitude, high frequency sounds, Litman, diaphragm. Okay? Ha. So that is called high-pitched blowing murmur is the classical feature in case of aortic regurgitation. In aortic regurgitation, when especially it is severe, you also listen a murmur called Austin Flint murmur. So once more, before we go to Austin Flint, early diastolic decrescendo murmur with the patient leaning forward in the neo-aortic area. Can you appreciate? This is second left intercostal space, pulmonic area. This is second right intercostal space, aortic area. And this is fourth parasternal, left sternal border. It is neo-aortic area. For aortic regurgitations, murmur. Ask the patient to hold the breath. Now, what is the pathophysiology of Austin Flint murmur, which is seen only in AR, which is severe, not mild AR or not moderate AR. Agreed? Now let us look into the pathophysiology. Very simple. Aortic regurgitation is happening from aorta into left ventricle. When is that happening? When the ventricle is undergoing diastole from atria. Agreed? Atrium is pushing the blood into the ventricle, and the ventricle is supposed to not receive anything from the aorta, but because of the regurgitation, it is happening. Agreed? So, if this regurgitant jet is strong, when the AR is severe, then it will provide a resistance to the flow of the jet coming from atrium into left atrium into ventricle. Even though the valve is not stenotic, though the valve, mitral valve is not stenotic, it is normal, the flow which is coming from the left atrium into the left ventricle found a resistance because of a strong jet which is that of the AR jet. And that creates the turbulence which is called the Austin Flint murmur. Henceforth, Austin Flint is a sign of a severe AR, not a mild or moderate AR, is what you need to remember. So examiner will ask a question. भाई आपको तो diastolic murmur सुनाई दे रहे हैं. How do you say it is Austin Flint? Why not it is mid-diastolic murmur of MS? Then what will you tell? Oh, come on, sir. Already the PG told me that it is AR, not MS. Huh? If you don't know, you also go and ask the PG. You won't tell that, no? You will tell. Third, MS will lead to a loud S1, which is not seen in AR. Then what will examiner will say? Ha ha. If it is a very chronic MS, which is calcified valve, probably it is not causing loud S1. Just because it is not causing loud S1, how can you tell that? How can you tell that it is AR Austin Flint, but not MDM of MS? Examiner will ask you, right? So, Gita is in love with you not because Sita is not talking to you. That kind of imbroglio this is. You can't infer Sita slapped you when you proposed love because Gita is in love with you. You can't conclude that, right? So, situation is like that. So, loud S1 alone cannot support you to say this is AR. Then, second, sir, If it is diastolic murmur of mitral stenosis, it has one special property. Instead of the diastolic Austin Flint, if it is diastolic murmur of MS, it has a special property. What is that? It will have a presystolic accentuation. What is the meaning of presystolic accentuation? I'll tell you. In case of mitral stenosis, the mitral stenosis murmur is diastolic. When the atria is, blood is going into ventricle. So the other day we discussed the ventricular diastolic has three phases. First 1/3, second 1/3, last 1/3. Why ventricle get filled from atrium in the first 1/3 of diastole, ventricular diastole? Because atrium is fully pregnant with the blood, ventricle just finished its systole and empty. That's the reason the pressure difference is the driving force. Second 1/3, why will it occur? Newton said, देखो रामो, एप्पल ऊपर है और नीचे गिरेगा क्योंकि जमी को आकर्षण शक्ति है. Atria are at higher level than the ventricles, and gravity will pull down the blood from atria into the ventricles. That is the second 1/3. Last 1/3, mother-in-law wakes up और बोलेगा, बहू कॉफी कहाँ है? कॉफी नहीं बनाया अभी तक. So the atrium will wake up and push the blood into the ventricle. It will kick the blood into the ventricle. So the contribution of atria is only as much contribution Chaitanya Narayana has on our life. We prepare ourselves and get the top rank. Coaching gurus will take the credit as much as atria. Agreed? Now, if there is a mitral stenosis, if there is a mitral, अरे क्या हुआ उसको? If there is a mitral stenosis and blood is negotiating through that stenotic valve, it is leading to the mid-diastolic murmur. During the last 1/3 of the diastole, because this atrial contraction, this murmur become exaggerated. That is called accentuation. When is it happening? At the end of the diastole and before the systole. Hence it is called presystolic accentuation of a mid-diastolic murmur of the mitral stenosis because of the contraction of the atria during the last 1/3 and trying to negotiate the blood through a stenotic valve. But that's the reason. What will happen? It will exaggerate. Last me. And then once more. That is MS. Then what will you tell examiner? Sir, I only heard diastolic murmur, sir. No presystolic accentuation. Henceforth, this is not a MS. MDM, it is a Austin Flint murmur, you said. But there is an exception to that. If the patient is having atrial fibrillation, which is common in severe MS, when LA become dilated, it will go into fibrillation. Then this last 1/3 accentuation contributed by atrial contraction is no more contributed. There's a reason AF will cause presystolic accentuation go away. There is an MDM without presystolic accentuation if there is a concomitant AF. That is the reason. What will examiner will tell? Hey, you are not listening to the presystolic accentuation. Could be because of the AF. It is not always a hard and fast rule that it should be there. Right? So that is the reason how many defenses of you have failed. A diastolic murmur with loud S1, not always. A diastolic murmur with loud S1 is not always seen in MS. When the valves are calcified, loud S1 can become soft. Agree? So that is the reason a mid-diastolic murmur without loud S1 need not be always due to Austin Flint. Defense 1 gone. A mid-diastolic murmur with a presystolic accentuation is not always a feature of MS, because when the MS develops AF, the presystolic accentuation is gone. That defense is also gone. Then suddenly what will you do in the exam hall? Yada yada hi dharmasya glanir bhavati bharata. Suddenly the wisdom blossoms in the exam hall. Sir, it is Austin Flint, I know, sir. Not only because the PG Srinivas told me, it is also because Austin Flint occurred only with a severe AR. And I will show you the signs of severe AR here. What is the sign of severity of AR? Typically in AR, there is something called Hill's sign. You calculate the BP in the upper limb and lower limb. A discrepancy more than 20 millimeters of mercury between the two is indicative of severe AR. That only occur in severe AR. So that is what you will tell the examiner. So Austin Flint murmur is a sign of a severe AR. It will mimic the mitral stenosis being a diastolic murmur, is what you need to remember. So quickly, Austin Flint versus true MS. What is the difference? Opening snap is not there in Austin Flint, only in MS. S1 is normal here, but generally expected to be loud unless calcified valve is there. Typically, both of them are heard in apex. But here, wide pulse pressure is a feature of Austin Flint, but not MS. They are the differences. Clear? Now, doctor. What is the pathophysiology? In AR, there is a LV volume overload. Why volume overload? LV pumped the blood, it came back, and regular venous return came together, will overload. That lead to dilated ventricle at a point of time. Then there is an increased left ventricular end diastolic volume. At the end of the diastole, you calculate how much is the diameter of the LV when you do 2D echo. So this regurgitated blood, this blood together will distend the LV, leading to end diastolic volume to be increased. And the regular stroke volume se bhi zyada hoga. Previous cycle regurgitant jet, this blood together, next time high stroke volume, that lead to bounding pulses. Then the diastolic pressure will decrease. Coronary perfusion decreases because coronaries get filled only during the ventricular diastole, not during systole. And that lead to development of angina. And commonly, if you ask one patient of AR, కొంచెం దూరం నడవంగానే అలసిపోతున్న డాక్టర్ గారు, fatigue, exertional fatigue is a feature of regurgitation, right? Now, why? Because whenever you are trying to exert, you expect more cardiac output, but here all the cardiac output is getting regurgitated. That's the reason you can't do exercise and increase the demand. Now, how is the pulse? Wide pulse pressure, that is increased systolic and decreased diastolic. Water hammer pulse. If you hold it and rise, it will collapse. There is a rapid rise and then collapse of pressure. Why collapse and why rapid rise? Because aortic regurgitation is a state of volume overload. So when the systole is done, then pressure will increase because more stroke volume is pushed out. But immediately at the end of the closure, all the blood is regurgitating and suddenly the pressure will collapse. It's like final year MBBS we entered, we thought of doing a different way, like our seniors want to read fast. But within 2-3 months after one posting is over, pressure down. What hammer pulse? I won't let that happen. Then Corrigan pulse is a bounding carotid upstroke. Quincke's sign, the nail bed capillaries will start pulsating. Demusset sign, the head will be bobbing with pulse. Because of the high stroke volume delivered, the head will be bobbing with pulse. So let's look into why there is a wide pulse pressure, increased systolic, decreased diastolic in AR. ChatGPT, D2D deal. In severe aortic regurgitation, at the time of the systole, the amount of the stroke volume that is being pumped by the ventricle is increased. And that is ejected into aorta. That leads to rapid high systolic upstroke, which is a bounding pulse. But during the diastole, the blood rapidly leaks back from aorta into the left ventricle. That will decrease the aortic diastolic pressure, which is called runoff. It runs off back into the ventricle. So that is the reason the aortic pressure, diastolic pressure will fall down. And that leads to rapid collapse of the pulse, leading to the wide pulse pressure, water hammer pulse, increased systolic. So if you check the BP, this patient will have 120/40. 120/40 or 130/40. Or, of course, systolic will be increased, no? So it will be around 150/40. Agreed? There is another important rule. A patient of aortic regurgitation who is supposed to have 150/40, instead of 150/40, if he is having 110/40, what does it indicate? If this AR is associated with AS, AS will prevent delivery of increased stroke volume. Even if regurgitation is having more stroke volume, when it need to deliver next time, this stenotic lesion, which is a fixed obstruction to the cardiac output, will prevent the output. That's the reason the systolic BP, which is supposed to be 150, instead will be 110. And that is called systolic decapitation caused by the AS, which pervaded into the AR. All the time professors used to be like, there were great days of doing MBBS with some of the great, even now there are great teachers. Remember that everybody in general medicine or any clinical subject, how did they become all that? Only by passing through the stages you are passing through. So obviously, tomorrow when you become a teacher, will you not have every opportunity to teach? You will. But the whole problem is dysenergy. Diffusa urethral dysenergy, it is called. Students think teachers don't have interest to teach, and teachers think students don't come to my class. Beauty of learning. So, kabatti, catch hold of, you smell who is the teacher. Right? Just like IAS officers. IAS officers are like medical students. Ministers are like teachers. The moment a new minister arrives after election is over, first thing IAS officer, what he will do? Inko subject hai ya nahi? A kali fake stamp hai kya CM ka? Right? If he really has a subject, this fellow also will work with him. So when you go, you should identify who will teach me skills. who will teach me knowledge. And then you need to go along with the stream to learn. Okay? Good to the concept. So big ejection, rapid runoff is equal to bounding and collapsing pulse is what you need to basically remember. So collapsing pulse is the hallmark of a severe AR. And that is also called Corrigan pulse or water hammer pulse is what you need to basically remember. So now, doctor, there are two types of aortic regurgitation. One is called acute AR, other is called chronic AR. Chronic AR ka hota? If at all you have rheumatic heart disease, that lead to chronic AR. When do you get acute AR? When someone is having an infective endocarditis with especially fungi. Fungal vegetations will be big. And they lead to sagging of the valve, leading to acute regurgitation. But in acute regurgitation, there's acute rise in pressure in left ventricle, reflecting on left atrium, leading to pulmonary capillary pressure increase and leading to pulmonary edema, hypotension. It is an emergency. Chronic AR may, that high pressure is accommodated by the dilatation of the ventricle. So LV dilatation is the compensation in chronic AR. That is the reason what do you get? Wide pulse pressure, peripheral signs and all that. Acute AR, no time for LV to dilate and adapt that high pressure. That reflects to the backward chambers and act on the pulmonary capillary wedge pressure, leading to the development of peripheral edema. Pulmonary edema is what you need to remember. So there is one more scenario where you get acute AR. Whenever there is any acute aortic dissection, the dissection blood will seep and lead to dilation of the aortic valvular ring, leading to acute AR. Right? Is what we need to remember. So these are the increased pulsations in the capillaries in the nail bed, which is called Quincke's sign. Then the bobbing of the head with every cardiac output is called the Demusset sign. Of course, you find increased pulsations in the uvula, lot of places. There are at least some 10 named signs for AR. When we were undergraduates, AR used to be easy to find. Why? Most common cause of AR is syphilis. Syphilis leads to endarteritis of the valve, the vessels supplying the valve. That lead to aortic regurgitation, very common. We used to have one patient, regular exam case, syphilitic patient with aortic regurgitation. He used to tell, hey, Adaga, Idavatto. He used to ask us, here, Marmar. Saru, Ida and Adutadu. Ida Gad, Ida and Japale. Venkatapaya patient. So, regular. For every exam, they used to put him as a exam case. So, aortic, similarly, Marfan syndrome patients, those who are having severe hypertension also, regurgitation is seen acutely. Bicuspid aortic valve, you will find rheumatic heart disease can cause infective endocarditis, especially if it destroys the cusp or if it is a heavy fungal vegetations, can lead to development of an acute AR is the etiology. Now, what is the hemodynamic logic that you need to know in AR? In AR, what is happening? The regurgitation is happening. The regurgitation is happening, right? So, anything that increase the afterload will worsen, decrease in afterload will improve. So, pregnancy will improve, right? That we use vasodilators like nifedipine, nimodipine, calcium channel blockers, right? in order to reduce the afterload and increase the forward flow and improve the cardiac output. Whenever there is any bradycardia, what will happen? The diastolic filling time of the heart will become increased, bradycardia, and that lead to more regurgitation to occur. Bradycardia is not good. But tachycardia decrease the diastolic filling time and decrease the regurgitation, which is the diastolic event. So it is beneficial in case of AR. So this is how you have left atrium, left ventricle end, it is going into aorta and the regurgitation is happening. Right? So 100 ml forward, 40 ml backward. And the regurgitant fraction is what you will calculate. Right? And how will be the ejection fraction? Next time when it is ejecting, the regular venous return plus the regurgitant jet together will try to maintain more ejection fraction does not fall down in AR. Normal ejection fraction is 65%. So here suddenly you will find 70%, 75% also. But that does not mean patient is good and healthy. The EF will either maintain or increase because AR is a state of volume overload and an increased systolic output. Agreed? So, common questions. What is the first line? Transthoracic echocardiogram. In that, what will you look for? The size of the LV and LV end diastolic pressure size. End diastolic size of the LV, whenever it increases, that is an important indicator. Then, effective regurgitant orifice area. When you do the Doppler, no, you look for the regurgitant jet. How much is the surface area of this jet, regurgitant jet? That is called effective regurgitant orifice area. More than 0.3 means it is a severe AR. Similarly, how much regurgitant fraction is happening? If it is more than 50%, that is a indicator of severe AR. That's how echo is an important investigation. So how do you manage? If it is a symptomatic patient with severe AR, then aortic valve need to be replaced, not repaired. Unlike in mitral stenosis, there is a chance to repair the boyfriend. Aortic valve is, after 10 years marriage, if the husband is philandering, better burn him and throw him into dustbin. Then LV ejection fraction expected to be either 55, 65 or above. But if the ventricle is, due to the regurgitation, if the ventricle is dilated and failed, right, that time once more EF will decrease. So EF in case of AR, if it is 55 and above is okay. But the moment it is less than 55%, surgery, even if the patient is asymptomatic, very important. Then LV end systolic diameter more than 50 mm. Surgical indication. LV end diastolic diameter more than 65 mm. That is also early surgery recommended. So these are few values when it comes to clinical management of a patient of AR. Right? So acute AR, how do you manage? As I told you, anything that decreases the afterload is good. So you try to give IV vasodilator like nitroprusside, decrease the afterload and improve cardiac output in acute AR. Acute AR, the first thing, decrease TPR. Give inotropes, support circulation, bridge to surgery. And urgent surgery is a definitive management of acute AR is what you need to basically remember. Then chronic AR, what will you do? You give ACE inhibitors, ARBs, diuretics, everything to decrease the afterload. And you need to do serial echo. Monitor the size of the LV because LV end systolic, end diastolic diameter is an important indication when to do the surgery, right? And early surgery will prevent irreversible LV dysfunction, is the rule. So what are the important exam traps? Never use phenylephrine because it is a vasoconstrictor, which increase afterload and worsen AR. And acute AR, never delay surgery. Don't rely only on symptoms. There may be a asymptomatic patient whose LV is failing. So check LV dimensions. Don't give beta blocker. Beta blocker will decrease the heart rate, increasing diastolic filling time. That increases the regurgitation. Do not miss acute AR because peripheral signs like wide pulse pressure will not be a feature of acute AR is what you need to remember. Now, what are the different scenarios? Marfan root dilatation. What do you expect? Which valvular heart disease? AR. Bicuspid valve aneurysm. You need to do root repair and AVR. Marfan root dilatation, early surgery needed. Pregnancy, generally AR is well tolerated. Dialysis, hypotension, it can worsen the AR symptoms is what we need to remember. Right, doctor? So, these are the few things that you need to be very sure when it comes to aortic regurgitation. So, doctor, I didn't have breakfast, very hungry. So, thanks for attending this wonderful session. And next week onwards, we will try to plan a little longer session. And Saturday, you can come. College busy together. Sunday was the only convenient time. Okay, we will do that way. Okay, thank you. And you are there in the group, no? So Monday to Saturday, some of the other live online session we will have. At least attend that.